I want to thank Dr. Paturi for including me in this wonderful organization for able to speak. It's my honor to talk about um, really to talk about a very important topic that is cardiovascular risk in South Asians. Let me start with my slides. So can anybody see my slides?
Yes,
Yeah.
doctor.
Yes, we are able
Okay,
to see.
great. Okay, so I'm talking about a really important topic. Only Daniel would know what this B is. It's for the Cincinnati Bengals who are playing in the AFC Championship, our football team here. Big step. We're talking about the risk of cardiovascular complications in South Asians really empowering our community. When you talk about South Asians, a lot of my colleagues get confused. They think Chinese and Japanese are part of South Asians, and they're not. It includes countries such as Pakistan, India, Bhutan, Sri Lanka, Bangladesh, Myanmar, formerly Burma, Tibet, Nepal, Maldives, and I'm thinking sometimes even Afghanistan. And there's a large community, it's the fastest growing community, ethnic community in the United States. I'm gonna start off with a case scenario. This is actually my wife's first cousin. He's a 46-year-old, lives in Columbus, Ohio. A South Asian male, healthy guy, tries to exercise, does the usual things. He calls me one Saturday morning saying he has nausea, shortness of breath on a Saturday, and he's sweating. He just does not feel right. He thought it could have been something he ate. Never thought it was his heart. So I told him, go to the local hospital and call me. He calls me, he gets checked out, and next thing you know, he said he was having a heart attack. They're wheeling me to the cardiac cath lab, and he got 2 stents. His risk factors, that is what is our risk for heart disease, is based on risk factors, some standard risk factors. He's mildly obese, not really big guy, mild hypertension, which he controls with diet. He has no family history. He does not smoke, which is very common in South Asians. He exercises intermittently. He is not a diabetic, but his blood sugars, when he showed me his lab work, were elevated, but it was never really addressed. He does have a lot of stress with work and family, and you'll see that is a common scenario among South Asians. His lipids 3 months ago, his lipid profile showed a total cholesterol of 190, which is okay. LDL is a little too high. That is the one that causes all the blockages, and I'll show you. It's HDL, which is the good cholesterol, which is the larger particle, which protects against heart attacks, is low, very common in South Asians. And it's triglycerides, which is also what we call atherogenic, which causes plaque, which causes heart attacks, was elevated. So he had all the setup for having a heart attack, but it never really raised any flags with his physician. But luckily, he's doing fine. So what is the magnitude of South Asians and cardiovascular heart attacks? We make up 25% of the world's population. We account for more than 60% of the world's cardiac patients. Whether you live in India, whether you live in all these countries that were represented, such as South Africa, United States, Canada, New Zealand, the risk does not change. It is a leading cause of death in India, Pakistan, and Bangladesh, and the rates continue to rise. But of interest is that it is one of the fastest growing ethnic population groups here in the US. In 2030, I believe, we will be the #1 ethnic population in terms of numbers in the United States. And when you look at the data, this is mind-boggling, is that our risk of heart attacks when compared to white Caucasian Americans is 4 times the normal US population. It occurs 10 years earlier. And once we have a heart attack, the risk of having or dying from it remains quite high. And we think that when we migrate to the United States, Canada, and so on, when we migrate, that our risk goes down, but it does not. When you look at in India itself, I give it for example, or any South Asian country, in India, rates of cardiovascular deaths have doubled to 36% as the cause of death in a matter of a decade. And this is mostly due to rapid economic development, the urbanization of India, epidemiological changes as we talk about mass migrations, a lot of rural area people moving to the big cities, looking for jobs, economy, and so on. Sedentary lifestyle, that is, we're not very active anymore. We have adapted the Western lifestyle, and of course, fast foods is so readily available, especially now with DoorDash and all that, that it's very easy and accessible. Usually this kind of change takes decades. When there is economic development, epidemiologic changes in a Western country, it happens over decades. But this actually has happened in India in a matter of 1 decade. When you look at the global cardiac risk score, age at risk of ischemic heart disease, that is blockages in the heart, per 100,000 men, you look at it in red, anywhere in red is quite worrisome, including Africa, India, and other South Asian countries, along with Russia and the US. It's not that bad. In fact, US and other Western countries have reduced the risk and the burden of cardiovascular disease. Whereas in India, Pakistan, Bangladesh, and all that, the numbers continue to grow. And when you break it down by states in India, the state I come from Kerala, it is the #1 killer amongst men, cardiovascular disease. I'll go over why that's the case. So it is a problem that is here to stay, and it migrates with you when you go to other countries. When you look at some of the data, again, what are the risks if you're diabetic versus non-diabetics? There's a threefold increase in South Asians in native countries and abroad in terms of heart attacks. In non-diabetics, is 11.4%. In diabetics, it over doubles to 21%, whereas in whites, it's only about 13% in diabetics. And in South Asia, in the US, are the highest incidence of diabetes and pre-diabetes. That is when your insulin levels are high, your blood glucose is high, as my wife's cousin was. And when you migrate to another country, such as Japanese migrating to Hawaii, only after 2 or 3 generations do they increase their risk of cardiovascular disease equivalent to the United States. Usually immigrants, they fall between their home country and their adopted country in terms of risk of CAD. In South Asia, this is not the case. Our risk remains higher than any other ethnic group in the US. This happened in a matter of a decade or two. What is the crux of the problem? This is where all the action happens, as we say. This is the inside of an artery. This is a cartoon representation. This is where all the inflammation, all the heart blockages happen. This is in your heart, going up to your brain, the carotids. And over time, as your lipids get abnormal, you become a diabetic, you have high blood pressure, you smoke, this plaque builds up. And what causes a heart attack is that this plaque ruptures. It blocks off flow to the heart or to the brain, gives you a heart attack or a stroke. This, some of you physicians will recognize is a coronary angiogram. This is what we do. We put the catheters up, and the catheter engages the coronary artery. And what you see here is that there's a piece missing here. This is not good in that there's a blockage here. This is in a vegetarian with no previous heart disease, South Asian, and you see several blockages here that had to be treated medically with stents. Well, what about if you live in rural areas versus urban areas? We know that in urban areas, in the big cities, there's a higher BMI, body mass index. They tend to be more obese. We're more sedentary in the cities. We're more stressed in the cities, and we have more obesity, especially abdominal, which is what we call more atherogenic. That is what causes blockages in the heart and in the other arteries. In the rural, they tend to be more active. They tend to walk to most places. They have lower BMI, waist to hip ratio, and that's one of the things we look at in South Asians. Lower incidence of obesity and less diabetes. Even though they may eat the same amount, they probably eat less of the junk food or the Western foods that we eat now in India, and their risk is less. But urban South Asians have the same high risk of CAD, whether they migrate or not. But the rural South Asians have a 50% less risk. So being active, living out in the open has an advantage. Why? Well, what sparked my interest about South Asia, the cardiovascular? I did not know all this till I read this article in the New York Times by two physicians, one at UCSD, one at Northwestern, who looked at what they did was they did an NIH-funded study. They had a great moniker for this: many mediators of atherosclerosis in South Asians living in the USA, or MASALA study. And they enrolled 1,100 patients. What they did was they looked at them prospectively. Those are of South Asian descent in the Chicago and Bay Area, which, as you know, if you know the United States, there's a large population of South Asians. And what they wanted to know was, why are these people having more heart attacks at an earlier age, and what can be done possibly to mitigate this problem? And what they did was, the results were that what they found from their study, this was just an epidemiological study, the South Asians have a 4 times greater risk for a cardiovascular event, as I had stated earlier. And it occurs 10 years earlier. And we have a higher mortality. So if you have a heart attack or a stroke, we tend not to survive it. And the reasons for that, what they extrapolated, they did some calcium studies, and I'll show you on that, coronary calcium studies. They thought the reasons for that was increased adiposity, and I'll show you some slides on that. Increased diabetes mellitus, as we have talked about when we across the globe, as diabetes is an epidemic, especially in South Asians. Increased insulin resistance, which is what we call pre-diabetes. As you gain weight, as you eat more carbohydrates, your insulin levels go up and you become resistant to the effects of insulin in lowering the glucoses. And the body composition, I'll show you some slides on that. But the one thing that has never been worked out so far is there a genetic component? Do we have a genetic predisposition for developing coronary disease or cardiovascular disease? Possibly, if you look at the data from England for the repository of Bangladeshis, that there may be a genetic cause of the genetic marker. Also amongst Sikhs, also there may be a genetic marker, but nothing across the board in South Asians. When you look at the biology of the atherosclerosis, well, why does this happen? Well, the biology of the atherosclerosis is complex, but it's no different. In that cartoon that I've shown you, it is a plaque ruptures, gives you a heart attack or a stroke, and you suffer the sequelae. But here's the problem. Among South Asians, there's the increased prevalence of known risk factors for heart disease. We have a lot of insulin resistance, that is pre-diabetes, metabolic syndrome, that is where you're obese and the obesity is in the belly. You have high glucoses, and you have a high triglycerides and a low HDL and a high waist to hip ratio, and you're sedentary. That is called metabolic syndrome. Those people go on to become diabetics. Type 2 diabetics is almost a pandemic in South Asian countries, and 120 million South Asians across the globe will have it by 2030. You look at it when you compare to Caucasians, that 23% of South Asians have it versus only 6%. Our HDLs are low, which is a reflection of poor dietary habits, lack of exercise, and metabolic syndrome, and diabetes. We also have a marker that is called Lp(a), which is a subparticle in the lipid profile, which is not routinely checked, not in the United States as a marker, but it should be checked in most South Asians. This is highly atherogenic, and it goes along with high triglycerides and low HDLs, and these all have effects that work together to increase our risk of heart attacks. Our incidence of obesity is higher, but the problem is that it's abdominal obesity, but our BMI, which is a body mass index, which tells you whether you're obese or not, is always lower when compared to Caucasians. So for the longest time, they used the BMI for the Western population and felt that South Asians did not fall under this category. I'll show you some data on that. We also exercise much less. We have a higher incidence of high blood pressure, which goes untreated. Inflammation, if you look at the inflammatory markers, our diets are pro-inflammatory. When I showed you that picture of the cartoon of the plaque, it is all inflammation, and that is what causes it to become unstable and to cause a heart attack. And possibly genetic, thrifty gene hypothesis. When rural India, a long time ago, pre-independence, when food was lacking a lot of times, your genes would shut down your body's function and preserve all the carbohydrates and all the calories so you can find food later. And maybe that gene continues to work now, but we have enough access to food, we tend to eat more and be less active, so you store that as fat. Again, just a hypothesis. But here's a problem. We have all the risk factors I had shown you, but our cholesterol levels, as in my wife's cousin, did not raise a red flag. The LDLs tend to be okay, not too high, nobody's worried. Our BMI, body mass index, we tend not to be obese, would tend not to raise any red flags. And there are also what we call risk calculators that we use, which are apps now, that you can calculate your patient's cardiovascular risk for 10 years, 30, 20 years, 30 years. But they say there's a disclaimer that you cannot put this for South Asians. It underestimates their risk. There is no calculator for South Asians. A lot of times, hypertension, diabetes goes untreated for many years. We think we're protected because many of us are vegetarians, and I'll show you some data on that. We also have a big problem, whether you live in the United States or any other country, lack of access to care, lack of cultural barriers such as language, transportation, lack of familiarity of the location that leads you not to get adequate care. And this is not something that I'm just something small. In the Journal of American College of Cardiology, which is our governing board, it was a front page of their journal talking about the risk of South Asians and heart disease. Well, what about fat distribution, just to break it up? When you look at the difference, when you look at a side view, this is your front, this is your back, your belly button's here, subcutaneous fat and some visceral fat, that is where the organs are, a little bit is okay. When you have a lot of fat here, just in the front of the belly, and very little visceral fat, moderate risk. But this is what South Asians have, this visceral fat. So when you do a body mass index, it doesn't show up that you have a lot of fat hiding within the belly. You have very little subcutaneous fat. And the way to see this is a CAT scan. This is looking from the feet up. This is your spine and your ribs. That when you look at South Asians, this is the subcutaneous, it's black, it's subcutaneous fat pattern, which is common amongst Westerners. But among South Asians, most of it is here between your organs. And this is highly atherogenic. This leads to increased glucose absorption, which gets converted to fat, which gets deposited in the arteries. So it hides well in South Asians, but not in everybody. Again, the body mass index, as I mentioned before, the body mass index is a screener for obesity. But we have the highest rates of overweight and obesity, 25% in men, 35% in women. But we develop insulin resistance, that is pre-diabetes, at a lower BMI, probably due to the visceral fat. And to capture South Asians as a risk for heart disease, as capture the obese, the WHO in 2002 and the American Diabetic Association dropped their BMIs to lower to include South Asians, so they can be included as at-risk patients, and so treatment can be started appropriately. Well, why do we gain so much weight? As you know, if most of you South Asians will recognize this, and I'm sure you're hungry for this stuff, it's all the stuff we eat at home. We do like our meals. We like breakfast, lunch, and dinner. We tend to revolve around meals. What is wrong with the typical South Asian diet? It is high in carbs. As I showed you, those foods are very high in carbs and low in fiber. When your diet is high in fiber, you reduce the absorption of glucose. You slow it down so your body has time to process it and get rid of it. It is high in saturated fats. We use a lot of ghee, palm oil, coconut oil, especially in Kerala, where I come from. And these are very highly atherogenic. They have a lot of LDL cholesterol in them. That's what leads to it, along with the high carbs. In Western countries, most of the animal fats are the major source of saturated fats. Whereas in South Asian countries and among South Asians, tropical oils, especially coconut oils, are the major source of fats that we eat. We don't eat a lot of beef and chicken and so on, because not only because of religious reasons, but also because of cost and so on. But we do get a lot of our fats from tropical oils. And most of our diets are high in sugar, which is converted to fat, high in fried foods, especially fried in ghee, palm, coconut oil. But we think that being a vegetarian protects us, but it probably increases your risk of what we call contaminated vegetarianism. Because vegetarian diets tend to be much higher in carbs, low in fiber, high in saturated fats, and high in sugar. And that leads to diabetes, high blood pressure, and leads to heart attacks. But the problem is it's easy to talk about diet, changing a diet, and getting rid of a South Asian diet. But really, our diet is a bond to our culture and our homeland. We all eat it and we all crave it. Our typical South Asian diet continued also is low in fish, a source of omega-3, which is protective. It does not reduce LDL, but it increases the good cholesterol, increases HDL. That reduces your atherogenesis. It is also low in green leafy vegetables and fruit. As you know, when we eat vegetables, it has to be overcooked. It cannot be crunchy. If it's crunchy, then it means it's undercooked. And for many of us, eating a salad is just unheard of. And fruits, we don't consume enough fruits. Alcohol, it's controversial, so whether it's protective, especially red wine, but it's not protective of South Asians due to the amounts we consume. We tend to do binge drinking. We also eat a lot of high fried foods, which increases LDL. When you look at Western vegetarian diet versus Indian vegetarians, remember what I tell my patients is Westerners become vegetarians for health reasons. We become because of religious reasons and so on. That the Western vegetarian diet, which is high in fiber, has lower levels of insulin resistance, insulin levels, and LDL because the way the diet is. So a lot of it, our risk falls on diet. You look at the diet in South Asia, look at in US, look at American consumption of vegetable oil. 20% of our calories now comes from vegetable oils. And processed foods, which you get in packages, have a lot of wheat flour, low fiber, high chickpea flour, and all these oils which help to preserve it and keep it on the shelf. They also tend to have high sugar, high sweets, high salt, because all salt is also a very good preservative. And the refined products are low in fiber, and this also increases your glucoses and increases your cholesterol. One thing I tell my patients is, if it doesn't look like something in nature, try not to eat it. And also, studies have shown that as we become more successful, we come to the United States, we come to Canada, New Zealand, and so on, trying to get more successful, we become much more sedentary. And studies have shown that as we climb the corporate ladder or the academic ladder or the hospital ladder, we become more sedentary. We walk less, about half of what our Western counterparts walk. But the traditional risk factors that I've talked about may just be the beginning. Other big factors, mental stress plays a big part. If you talk to a lot of patients here, they have a lot of mental stress. They're working hard. They're away from home. Their support systems. They have problems at work, at home, back home in India or Pakistan or wherever. Depression is quite a big problem, which is undertreated among South Asians, underrecognized, and is worse in women who sometimes tend to have more isolation and cutting off from social support systems. There's also another risk factor is lack of social support. A lot of people come here when they're older, they've lost the support that they had back home in India, Pakistan, or Sri Lanka, and they lose that, and that's another stressor. Also, protective social factors, not associating with your own people from your village or from your state, also is considered to be a risk factor. Access to barriers to healthcare due to location, transportation. A lot of my patients, elderly patients, have to wait for their kids to come home to take them for an appointment. A lot of my patients have been here for 40 years. Some of them, the wife does not work outside the home, does not drive. And a lot of times you'll see, even though the wife is my patient, the husband does a lot of the talking for them and makes a lot of decisions. So they're not open to talk about what their health condition, what they're worried about, what is bothering them. There's also cultural limitations. A lot of my patients want to see a female doctor rather. Language barriers, which I always ask my patients when they come to bring, if they have any language issues or they may have any concerns, that they should bring a translator with them. These are all together thought to play a role. So it's not just the traditional risk factors, but these which are a big part of the whole way of living in this country. But this is just a tip of the iceberg. What do I tell my patients? What can you do? You don't have to come and see me. If you're going to see your doctor, ask these questions. So see your doctor. Don't be hesitant. Get your lipids checked. Get a fasting lipids. And I tell them 12-hour fasting. Get the subparticles. These are elevated in South Asia. This is not part of what we call the lipid panel. Check inflammatory markers, which I had mentioned that the plaque is just inflammation. And the higher the inflammatory markers, especially when you have diabetes, you have high blood pressure, you're stressed, these are the markers. And we think that cholesterol pill does reduce these markers. Get non-invasive imaging testing. And I will show you some examples of that. Start exercising, start moving, walking, whatever will get you moving. Whatever exercise you want to do that you can do consistently, go for it. Quit smoking, which is quite uncommon among South Asians, but any smoking just amplifies all the other risk factors. Lose weight, reduce your calorie intake, lose weight. Crash dieting never works. Sorry, I think I jumped ahead a little bit. Reduce your stress, meditation, talking with people, exercising will reduce your stress. Control your alcohol intake. See a dietitian, reduce your caloric intake, and that'll help you lose weight and you'll reverse your risk of cardiovascular disease. But this all has to be tailored to each patient. What works for one patient may not work for another patient. What about dietary changes? Simple ones: eat less calories, eat less foods with saturated fats. Your 20 to 25% of your total caloric intake should be from saturated fats, especially those cooked in vegetable oils. Eat a high fiber diet, that is, eat quinoa instead of rice. Eat salad. Salads are wonderful. Maybe a little bit of oats, but those are high in carb, but those are better. Whole grain foods, more vegetable, fruits and beans, nuts. Drink more water. A lot of times, studies have shown that hunger, when you feel hungry, is actually thirst. And try drinking some water that may reduce your hunger and not grab the nearest jalebi. Use olive oil and canola oil. I know olive oil does not cook well. You cannot fry things with olive oil, but use dalda and ghee sparingly. Eat foods rich in omega-3 and 6. 1 to 2 servings of fish per week. If you're a vegetarian, think about fish oil supplements. But the problem is that the supplements that is over the counter is not regulated, and it's unclear as to what additives they have in it. There are prescription fish oil which are quite good, but they're quite expensive. Avoid soft drinks. We tend to drink a lot of soft drinks. If you go to when I went to India a few weeks ago, everywhere it's available. Thumbs Up, Coca-Cola. You cannot get really Diet Coke and other this thing. And Fanta is also readily available, high in sugar. And again, just to reiterate, we walk less. Studies, as we become more successful, the more time we spend sitting. Most of our work now is from home. A lot of people, because of pandemic, and we tend to sit a lot. And we also have a lack of awareness of the importance of exercise, how important it is for our well-being. We tend to study a lot and to try and become more successful, and to climb the corporate ladder or the academic ladder, we tend to exercise less. And there's also cultural barriers to exercise. A lot of us don't feel comfortable, especially women, getting dressed up in gym clothes and going to a gym. But there are other ways around it. Studies have shown that if you do Bollywood dance, they did a study amongst 50 women, Bollywood dance for 6 weeks, just amongst themselves, that they lost 10% of their body fat, their blood pressure came down, and their blood sugars came down. And this is actually one of my favorite slides. It will lift for samosa. Any kind of exercise is good. But what are the benefits of exercise? It helps prevent diabetes. If you are pre-diabetes, you lose weight and you exercise, you reduce your risk by 30%. There's no pill that reduces anything by 30% when you think about it. So exercise is a win-win. It helps reduce weight, improves muscle mass. Our counterparts, whites and African Americans, have much higher muscle mass than us, and they're able to tolerate all these insults to the body, whereas our bodies are not. So walking, aerobic exercises along with some resistance training is very good. It helps manage mental stress. It lowers blood pressure. It improves HDL, the HDL cholesterol, which I had told you was the good cholesterol, which is low in a lot of South Asians. It helps strengthen bones. We still do get osteoporosis. Also, your kids and your grandkids who are second generation, third generation Indian Americans, they learn from this and they also pick up on these habits. And it probably delays aging. But the problem is that risk factors are heterogeneous. Just treating one risk factor doesn't allay your risk of having a heart attack. And sometimes you need some more evidence to see that, yes, you've got some problems going on. We need to deal with it. Sometimes what we do is we get a coronary calcium score. It is a non-invasive CAT scan of your heart. It takes about 7 minutes. You get the results back in a couple of hours. What this is, again, from the feet up, this is your spine, this is your heart. And what you see here, this is the plaque that I had shown you in the coronary arteries. And this is what it causes a heart attack. And this can be picked up non-invasively. A lot of my patients need convincing that they need to take a cholesterol pill, and sometimes getting a calcium score that shows plaque convinces them that they need to improve their lifestyle and take the medications. Coronary CT is an advancing technology, which is fantastic. As you can see the coronary arteries. This is what causes a heart attack. This is where the blockages occur, and you can tell how much blockage they have, how significant it is, if there's any valve problems or any other problems in the heart, with a simple CAT scan of the heart. It's not a regular CAT scan, but the machine has to be gated to your heartbeat, and they do slow down your heart rate to get better images. But this is, I think, is the future. You don't need an angiogram, that an invasive angiogram. You can get this with a CAT scan. Here's a problem. Let's say we already have blockages. We need to have an angiogram or a stent or a bypass surgery. In a typical South Asian, our arteries are very small. This is the catheter engaging the coronary arteries, 2 millimeters. These vessels are so small, you have to have at least 2 millimeters of vessel to graft a bypass graft or to put a stent in. So our arteries are small. We have a heart attack, and you cannot get a stent in there or a bypass graft. When you look at Americans, what we say, they have big pipes. These arteries are huge, and these you can easily graft into or stent. So you don't want to get to this stage. What about the question that comes up with a lot of my patients? Are the cholesterol pills safe? They are. These are the typical cholesterol pills that we use: Lipitor, Crestor, Zocor, Pravachol, different names in different countries. Probably the most effective in South Asians due to a gene deletion is Crestor. And is one of the most studied drugs in cardiology. Cardiology is very evidence driven. All the stuff we do is due to what evidence that we found in studies, randomized studies. And it does reduce it across the board, a 58% reduction in cardiovascular death in men and 48% in women, which is quite good. The liver abnormalities that occur sometime with these statins is very uncommon. And in fact, it may make the liver function better. If you have a fatty liver, if anybody's told you have a fatty liver, it's time to get your cholesterol down and get your health checked out. Memory loss, some of them do cross the blood-brain barrier, but it's never been proven. It is anecdotal. Actually, they may improve your memory, because if you get a lot of lipids crossing into your brain, that causes plaque, and that leads to dementia. Some of my patients refuse to take a cholesterol pill, but sometimes we give them red yeast rice, which is a supplement here that you sprinkle on your food. It has some statin in it, but I never tell them that. It does reduce your cholesterol somewhat. And taking a cholesterol pill protects not only against a heart attack, but against stroke, heart attacks, and blockages in the legs, what we call peripheral vascular disease. Really, the benefits outweigh the risks. And really, there are many ways of prescribing this as minimal amounts, but I tend to use it a lot, especially in my South Asian patients, even those that have no cardiovascular disease, but that have risk factors. I'm not going to go through this in detail, but you can reduce the plaque that I've shown you. You can cause reversal of the plaque, no guarantee. That can reduce your risk of the heart attack. But what a cholesterol pill does in lowering your cholesterol and exercise is stabilize the plaque, the cap of the plaque, so it doesn't rupture and give you a heart attack. And that reduces your risk of a heart attack. What is the future? What are we looking at? Well, we need outcome studies. There are very few outcome studies in South Asians. Everything is anecdotal, as I showed you in the MASALA study. It's not randomized trial, which is what drives evidence-based medicine. The American Heart Association, which sets out guidelines, has changed the guidelines to include South Asians as a risk factor for having heart disease. And the American Diabetic Association has done the same. And also looking at clinical trials specific for South Asians, I asked for some data from a large registry from across the world called GGH, and they asked for South Asians. What they sent me was Japanese and Chinese. So they really have to have specific clinical trials for South Asians. Specialized centers such as mine, we take care of South Asian. Me and my partner, Dr. Bhatia, two of us do South Asian cardiovascular medicine. The nearest center from here is 6 hours away in Chicago, and there's one in California, two in California, and one in New Jersey, from what I know. And we are, just as we speak here, I am doing a lot of local talks and nationally to increase awareness. You don't have to come and see me as a patient, but ask these questions to your doctor so you know your risk. And there's a Red Sari committee here, local dedicated people whom I work with, and they help also set up these talks and get the word out and do YouTube videos and TikTok and all that. And there has to be guidelines that are specifically for South Asians, risk calculators, diets, and exercise. And we are making our own pamphlets for diet and exercise in South Asia. It has to be culturally specific. Maybe look into more genetics. I'm working with a physician at Children's Hospital, a South Asian, about looking at LP little a and other genetic markers in South Asians. And there has to be public policy. There has to be increased awareness. Some of you may know a representative, Pramila Jayapal, who's of South Asian descent, but grew up here, who's from Washington State. She's a congresswoman from Washington State who has a bipartisan bill that funds South Asian cardiovascular research. Again, it is caught up in the politics of it, but that's a good step. And now we're looking now at targeting younger population, that is the second or third generation, because they are just as much risk. As they get older, they need to know about this and look into their risks more carefully. And this is our, the whole building is not mine. This is our building in Montgomery, Ohio, which is on the northern part of Cincinnati, where we have a cardiovascular clinic. The two of us have a South Asian cardiovascular clinic. And what do we do in the South Asian clinic? It is a culturally sensitive cardiovascular clinic. If South Asians like to see somebody professionally as their physician who looks and talks like them. And we do shared decision-making with patients and family members. I make sure that they're all on board, that what is going to work for your mom and dad or your siblings, and to come up with a plan. And I spend a lot of time promoting healthy lifestyle, diet, exercise, stress management, and knowledge gaps. You'd be amazed how many of my friends who are PhDs and other big entrepreneurs and all that have no idea what the risks are. And we try to target the knowledge gaps. We try to use non-pharmacological therapies, diet, exercise, stress reduction. And again, but if that doesn't work and you still are having a high risk for cardiovascular disease, we do tailored therapy. We're looking at genetics. We've not started yet, but we're looking at precision medicine also as part of the whole package we offer for South Asians. It is a personalized approach. You cannot do what works for one group that will work for the other group. And then we monitor. We see them back, see how their weight loss is going, their exercise is going. And we are partnering with some health coaches to help coach South Asian health coaches to reiterate the importance of diet, exercise, stress control, sleep, and taking medications. We did some, as you know, not every South Asian in the US has a job and is insured. A lot of who are undocumented. You'd be amazed how much in the Cincinnati area. So we did a health fair at the Islamic Center. We're going back in September. We did over 100 participants free of charge. We did blood pressure check. This is one of our nurses from the hospital, one of the doctors from the hospital. They checked blood pressures, went over questionnaires. We did ultrasounds, free ultrasounds of their heart, and we gave them a copy of the results that they could take to their doctor, and we discussed the results with them. We also did one at the Hindu temple, same thing, volunteers from the Christ Hospital. We did EKGs and echoes on about 100 people. We just did one at the Gurdwara. But despite all this, all the information I give you and all this stuff, there are some of us who are immortal, as you know. If you know who this is Wasim Akram, the great Pakistan cricket player, the great Indian cricket player, Sachin Tendulkar, and the never-aging Amitabh Bachchan, who continues to look young and healthy as ever. So some people just have very good genes, I think. So just to wind up, the most important, this is a very common theme you hear in India. Health is wealth. We never know its value until we lose it. As I'd said, if this occurred in one generation, this risk of cardiovascular, we can reverse it in one generation. And I want to thank you, and I'm happy to answer any questions or comments. And we want to thank you for the honor of being able to speak to you.
Thank you, Dr. Menon.
Go ahead, Joseph. There is one question in the chat. You may want to.
Okay. Let's see. Chat. Could you please enlighten how frequently one should get health checks done and a general specific test after 55 years? It's a great question. You should see your physicians annually for an annual checkup. And what I tell my patients, go fasting so you get your blood drawn for your cholesterol, your Lp(a), and whatever blood test, your blood sugar is very important, your glucoses. In terms of cardiovascular testing, you don't need an EKG every year. But if you are worried, if you have a family history of heart disease, you're a diabetic, a calcium score is very good. At Christ Hospital, they charge you $100 for it, but that's the best $100 you'll spend. And what I tell my patients, after 5 years, you can get another one. It's the exposure for CAT scan is about 2 to 3 chest X-ray. So it's not that much radiation. It takes about 7 minutes. You get the results back, and you can really chart a treatment plan with your physician. I don't recommend getting a calcium score before the age of 50 because that plaque that I showed you doesn't become calcified till you're into your 50s, so it won't show up on a calcium score. You don't need a routine stress test. I would not do that. And get your blood pressure checked and get your body mass index or waist to hip ratio, and make sure that you ask your doctor these questions. What is my risk? The other answer, next question is, what is the preference between atorvastatin and Crestor? Atorvastatin is Lipitor, Crestor is rosuvastatin. I think there is a gene, and the studies have shown that in South Asia, that they respond much better to Crestor. And as you know, Crestor is generic, and it does increase your HDL, lowers your triglycerides and your LDL. So whatever you can tolerate and you're willing to take, you should take. But I think I tend to reach for Crestor in most of my patients. If it's not on your insurance plan and they won't pay for it, atorvastatin is fine as long as someone keeps an eye on your cholesterol. I'm happy. I think Dr. Paturi has my email address. I'm happy to answer questions or concerns.